to the June 25th, 2024 ZSFG JCC. I'll ask Secretary Morowitz to call the roll.
Sure, I'll start with you, Commissioner Green.
Present.
And Commissioner Christian.
Present.
I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples.
Thank you. We have an announcement, and I really appreciate it. I apologize. I have to do a little surgery at 5 o'clock, and so because we have closed session items that we need a quorum for, we're going to change the order of the agenda, and I really appreciate everyone's flexibility on this. This is just an unusual one-off, and I didn't really have any choice in the matter. So Secretary Morowitz, do you want to just go over the order of things then?
Absolutely, and this is for us now and also anyone watching the video in the future. So we'll first do the approval of the minutes, we'll do the medical staff report, and then we'll go into closed session, and we'll come back to the regulatory affairs report, the CEO report, the True North scorecard update, the hiring and vacancy report, other business, public comment, and adjournment.
Thank you very much.
Sure.
So the next item on the agenda is indeed the approval of the minutes, and we have before us the minutes of our last JCC meeting. And are there any additions or corrections from either of us? I didn't see any. And is there a motion to approve the minutes?
So moved.
And I will second that. And then what about public comment on the minutes?
There's no, any public comment in the room? No public comment in the room. I think everyone here is staff. So all in favor?
Aye.
Great. So let's move on to the medical staff report.
Medical staff report.
Good afternoon, commissioners. My name is Gabe Ortiz, Chief Medical Officer of San Francisco General. So I have the pleasure of presenting our otolaryngology head and neck surgery service report. Dr. Megan Durr, the service chief, presented to our medical exec committee. You'll see from kind of what was shared with you, quite a vibrant and active department for kind of 36 faculty. So they have a pretty large footprint, including in the operating room, inpatient services, outpatient clinics. They have an e-consult. They staff their e-consult consult requests, inpatient consults, emergency department consultations, urgent care consultations, and they go to Laguna Honda. And so quite an active group clinically. They kind of presented really wonderful performance improvement work. I'll highlight their improving OR block utilization. It kind of feeds forward to some of the access and flow strategic initiatives that we'll talk about later within the True North scorecard. This service has done fantastic in terms of their first in-block utilization, hovering in the mid 90% on time starts, and that's just a tribute to their leadership and kind of the time that they've invested with their staff on that. One of the things that was really fun to see was their attention on wellness. If you kind of had a chance to look at their slides, lots of slides showing the teams coming together, and so that kind of was really great to see in terms of working hard, but also kind of paying attention to just the cohesion of the group and the support of each other. Their research was very interesting. They have a research fellow who has multiple projects focused on barriers and access to critical services like sleep surgery and other kind of types of OHS related diseases. And then I thought their community outreach and global health arm of their work was pretty unique. They have done multiple events in Chinatown and other areas of the city focused on cigarette and tobacco cessation and screening for head and neck cancers, which was really wonderful to see. And so in terms of the strengths of this group, really kind of a really strong mission-driven group, strong in terms of their educational, their clinical expertise, their research enterprise, and kind of the challenges included demands for services. They're seeing kind of quite a high demand. They're adding an audiologist to try to keep up with those demands. Also, they mentioned kind of here their equipment that needs to be upgraded and that is in the works by the end of the summer. It says here that they will discuss it with me. We talked about it immediately afterwards. By the end of the summer, we'll have new scopes for them to be able to make the most of their 4J clinic space. So it was really a wonderful report. In terms of some of the questions that were sent in advance, and thank you for those. There was one question around what services were delivered via e-consult. And so this service has over 2,000 e-consults, which is an electronic request for services for both OHS as well as another additional 2,600 for audiology services. It's a kind of most of the patients that come in initially through the e-consult service or workflow get seen in person eventually. So the e-consult serves as initial screening for ensuring the right workup is in place before the patient is scheduled. So the clinic appointment is actually, they make the most of the clinic time. So they have all the data that they need in order to guide the patient's medical condition. About 5 to 10% of the referrals are managed fully with the e-consult electronic communication back and forth with whoever was requesting. And there are two reasons for that. If the e-consult was primarily for hearing loss, they get directed to audiology. So it gets kind of sorted into the right stream of specialty. And then if the referral is for nasal obstruction or allergic rhinitis, the team will give instructions on medical management first via the e-consult platform before the patient is scheduled for a clinic visit to then potentially get reviewed for surgery. And so I also present the rules and regs, which were pretty minor for this department. And so that is our med staff report.
Thank you. Is there any public comment?
There's no public comment.
Right. Any commissioner questions or comments?
No, thank you for the concise report.
Yeah. I was just curious, are hearing aids covered for, individuals? The audiology component is so important, and yet I know many public plans don't necessarily cover hearing devices. Do you have any sense for how that's managed for this population?
I believe that the patients have coverage. I would need to reach out to the service chief to confirm. They have quite a robust set of consults to audiology. In fact, they're kind of overflowing right now and are in need to add an additional audiologist. They didn't specifically mention any issues with the services not being covered, and such a critical service as you highlight for our patients. But I can get you specifics in terms of whether there are patients that encounter barriers to accessing that service.
Thank you. Yeah, I'm curious because Medicare doesn't cover it unless it's MA. So I'm curious. I mean, San Francisco Health Network may, but it's interesting that that's one area where the cost of devices has not come down, despite what seems to be somewhat of a democratization of various devices and phones that help augment hearing and so forth.
Yeah.
The other thing, I'm so glad you mentioned the photos. They were so wonderful in this presentation. And I looked and it was different groups of people in different venues. And so you can really see, what you've said, the importance of building culture and support within a department that has obviously a lot of responsibility, a lot of stress, and is quite diverse in its responsibilities as well as in the array of services they offer. So it's always such a joy to look at the presentations and see that it's important to include that and to remind people that it's a team. So I thought that was really great. So with that in mind, I guess we do have to have a motion to approve the otolaryngology rules and procedures. So is there a motion to do so?
So moved.
And I will second that.
All those in favor?
Aye.
Oh, wonderful. Thank you so much.
Thank you.
Thanks so much, Dr. Ortiz.
So commissioners, now we can move into a consideration for closed session.
All right. Is there a motion to consider closed session?
I move that we move into closed session.
And I will second that. And is there no public comment?
All
And
those in favor?
Aye.
Aye.
Great.
All right, we'll go into closed session.
All right, and so I'm going to come close the doors, but we need the folks who are not at ZSFG employees to leave because this is legally, we're only allowed to have staff from UC and
I rebounded.
Did you?
Stuffiness and
Did you?
diarrhea.
Did you take Paxlovid or anything?
I took it and I was negative Monday, and I haven't rechecked because I used all my kits.
Mhm.
But I got really stuffed up Thursday, and I can't taste anything. It was really funny because I went to this restaurant called Lolita. It's supposed to be this Turkish restaurant everybody wants to go to in the Presidio.
We're supposed to be going on Saturday.
It was just that all the taste was the same.
Session, and we can continue with your permission, commissioners, with the regulatory affairs report.
Hello, are you able to hear and see me?
Yes.
Excellent. Okay. So Emma Moore, Director of Regulatory Affairs for ZSFG, here to give the regulatory report for the month of June. The first section of the report, pending surveys. You can see we will officially report in greater detail next month, but we successfully completed 2 weeks ago the Joint Commission Lab biennial survey. Overall, it went extremely well. They had 9 findings, one of which our lab is contesting based on they have exceptional knowledge about the process, but all of the findings I'm happy to report were low or moderate limited findings. So there was nothing that involved needing a preventive analysis, so essentially a root cause analysis, or that needed leadership involvement details out of that survey. So genuine kudos to the lab for that. They did exceptionally well. The Mental Health Rehabilitation Center from the Behavioral Health Center also had their annual revisit, annual survey from the Department of Healthcare Services. And so we do not yet have the plan of the deficiency report but that also went well. In terms of other pending surveys, I think the biggest one on the docket is the CDPH CMS complaint validation revisit. Officially, that would have been anticipated by yesterday. But as we know, the state and federal government show up when they decide. So we are anticipating that every day. And officially, you can see that there's no survey report, as this report details what happened in the month of May. So I will use that to segue to the plans of correction submitted. So for that CDPH CMS complaint validation survey that happened back in March, we received the plan of correction on 5/15, submitted it on 5/24. There were condition level, the collection of the findings rose to condition level, meaning that we're anticipating this revisit. And you can see there the findings that required responses and monitoring. I am happy to report we will have monitoring data in the coming months, but I'm happy to report that we actually were able to have our volunteer consultant, who's got quite a bit of regulatory expertise. He came today and did a visit with acute psychiatry, and his comment upon exit was, if he were the surveyor, he would have passed us. So we're not going to sit on our laurels. We're going to continue to prepare for that revisit, given the importance of it. But overall, we believe that this is moving in the right direction, and significant progress has been made in terms of this. As I highlighted last month, I do want to make the point that for the bulk of these findings, they're about the documentation, not about the care. And that is really the thing that I think every time we get notice that there's been a deficiency, that really is the lens that I try to look through it from that perspective. Moving to the second page of the report, you can see our reported cases for the month of May. So there were 2, one retained foreign object and one privacy breach, bringing the annual total up to 13. So I would say too early to say so far this year, but we currently are tracking well with fewer identified reportable events. The other thing, for the third month in a row, I will highlight that the HAPIs, again, you can see in 2023 there were 17, and that team has made it one additional month without a single reportable. So they really are to be commended for that. And the final page of the report does not have significant monitoring. So our plan moving forward is that the data from the Joint Commission, you can see there that 14 of the 82 findings have successfully completed their required thresholds that we set forth that we would do for Joint Commission. But that data has not yet gone to PIPS just because of the way that the meetings are scheduled. So it will be presented at PIPS tomorrow. And it will come to JCC in July. So overall, things are going well with that. We are PDSAing in a few cases where they're working to get compliance up, but for the most part, I would say areas are very engaged in that process, and the actions and fixes do genuinely seem to have taken, which is great to be seeing. With that, I will open it up to any questions.
All right, is there any public comment?
There's no public comment.
Any questions or comments?
Just that, as you noted, going from 17 to 0 and the happy that's pretty great for the second time in a row. That's great.
Yes.
Congratulations to them.
Yeah, I second that emotion. It's really great. I have no other questions.
Shall we move on to the next item?
Yes, the next item is the CEO report.
Thank you.
Dr. Ehrlich. Thank you so much.
Good afternoon, Commissioners. Susan Ehrlich, CEO. Always a pleasure to be here. So the narrative part of my report, I think the two big themes in this report are equity and our work on equity, and also, sadly, transitions. So I'll talk a little bit about both those things. So you can see first we had a really well-attended and very just joyful equity awards ceremony. That's item number one. We gave out awards to clinical staff, non-clinical staff, leaders, departments, and then we gave out the Career Achievement Awardee, was Andrea Turner, who has left us, but she was happy to receive that award in absentia. We wanted to call out Dr. Neil Poe, who was mentioned in Time magazine for being one of the 100 most influential people in health in 2024 for his work on fighting transplant bias. And there's more detail about that. We re-received our baby-friendly designation. We were one of the first in the state and the country to get this, and we have to go through a re-designation process. So we just received that again. That was lovely. So just to move on to the transitions part of the report, I have been going to a lot of retirement ceremonies recently, which is great in some ways and hard in others. I first want to comment on Dr. Elena Fuentes-Affleck. So Elena is retiring after 38 years of service at ZSFG. She came as a resident and then became a chief resident, but that was 38 years ago. She has served in many leadership roles, including the chief of pediatrics, the vice dean for academic affairs for the UCSF School of Medicine, and then more recently as the vice dean for UCSF at ZSFG. And I can safely say that that 2 years was a lot more challenging than she might have anticipated, chiefly because that was the 2 years that UCSF moved out of our brick buildings and into Pride Hall, which was a great move, and it's a beautiful building, and it's a much better space for those folks. But as you know, big space moves are never without challenges. So she is going to the AAMC as being the director of research following her retirement from UCSF, and we're really going to miss her. Fortunately, we have a very experienced interim dean in Jeff Critchfield, who you know very well. He has been onboarding for the last month or so, and we'll be very happy to be working with him in this new role. We also have been saying goodbye slowly to Terry Saltz, who is our Director of Capital Projects and Facilities. Terry started as a stationary engineer with us in 1989. So he knows everything about our campus, all 22 acres and 15 buildings. He knows it inside and out. Terry was the guiding and leading force behind us getting into our new building 25. And he has just been a pleasure to work with. We're actually reorganizing his area to make sure that we have the wherewithal to do the work in his, after his retirement. He will be coming back after 60 days as a Prop F on a part-time basis, so that's great. But I've learned so much from him, and the work that he does couldn't be more complex between the managing of the capital and facilities and understanding the financing of how all that work gets done. It's really incredible. So we were very, very grateful for his service. I was very privileged to be able to give the EMS Hospital Provider Award to Teresa Sandholt. She is one of our nurses in the emergency department. She got a big award from the EMS agency, and there were lots of leaders from the city there to celebrate her. That was really wonderful. And you both were there to recognize Dr. Leary. We give out a lot of awards at the annual medical staff meeting. That one is the best because it's always a surprise and always so well prepared by the vice dean. And there's nobody who deserves it more than Dr. Leary does. So I think I'll stop there with the narrative and see what questions you have for me.
Any public comment?
We usually wait until the end of the full report
Okay.
to public comment, but you all can continue now.
Any questions or comments?
No questions, but once again, just highlighting what amazing people have worked and continue to work and move up into new roles in the organization. It's continually impressive.
Thank you. I'm continually reflecting about what an amazing resource ZSFG is, and 150 years of just remarkable leaders of all different types. And so we celebrate and honor the people who leave, and there are other people behind them who step into their shoes and continue to do remarkable work. So it's really a privilege to be part of that.
Well, like all of you, and we saw this at the medical staff meeting, leaders develop great leaders.
Mm-hmm.
And I think we see that on the part of all of you in this room. And, we did hear that Terry Sauce was retiring because we got, the triple threat, bond people here at our last meeting on Tuesday. And he was so enthusiastic about the general. And when one of his colleagues says, well, he's going to be there for 2 days a week, everyone, he lit up. I mean, he came, he was wearing his ZSFG shirt. I was in the elevator with him and his badge, and he obviously loves the place. And it's so inspiring and touching when you have someone, regardless of what their role is in an institution, he knows where every pipe is and where every wall is, and he loves this institution as much as the physicians that work there, the nursing staff that works there. And we really felt that when we were at the meeting Tuesday. So it's great that he's not completely sunsetting himself at the general. Yeah, great.
Yeah, it's his home.
Wonderful.
All right, on to the data. So the emergency department, as noted in this run chart, has been getting busier. It has leveled off a bit. We're at 196 visits a day, and that cements our place in the city as the busiest emergency department in the city. And the average daily admissions follow that. Leave without being seen and leave without being triaged. As you know, we have a lot of very focused attention on this metric. And I would say that there are a number of factors that have led to this rise. It doesn't mean that we're not working very hard on it, but there are a couple of technical things that we're working through about how medications are provided to patients in that area. And as with diversion, over the past few months, we've had some challenges with staffing, which is a little bit ironic given the report you're going to hear from our HR. But we hope those will settle out over time, given that we're in a much better place with staffing overall than we have been recently. So we'll continue to be doing that improvement work and following it. Diversion is still lower than it has been at its peaks. But it has come up recently because of staffing. It's clear that that's been the issue. You will see it in June that it hits almost 50%, but we're hoping to see that come down. Just in the last few days, we've seen it do a little bit better, starting out July in a good way. I think most of the rest of these things are stable. The UCC, the urgent care clinic to ED transfers have been at a higher level, and that too we talked about last time is because some transitions in that area, and I think they're working on making sure that the work is standard in those transfers. And I think that is, the rest of these statistics are more or less stable. The ones that 4A, I provided some responses to that. We have closed 2 beds there because of seismic work, and we're working on plans to close them further, which we will keep you apprised of. The census is even lower than the beds we've closed, and that's primarily because of the situation we're in. The 4A unit is being very judicious about patients having a discharge plan following their stay. Our stay on this unit is about 33 days average, and we need to make sure it stays that way, especially during this construction period. So that's part of also what's driving that lower census. And then lower level of care is has stabilized somewhat. Our work there continues, and there's a lot going on that we can talk about more if you have questions about that. And then you also had some questions about the BERT team. They continue to do really good work. Their primary KPI is response without law enforcement present. And we can create new run charts that show their contacts over time. And I'll talk to the team about creating that. They are stable-ish based on just anecdotal knowledge of the evidence or of the data that they produce. Other questions about the data?
Now, should we ask for public comment or?
Yes. There's no public comment. There's no one in the
And
room
no
who's
one-
not staff, and there's no one who's a remote. So
Okay,
no public
wonderful.
comment.
Any questions or comments? No. Well, first of all, thank you for your answers. That made a lot of sense. And I think, this idea that the percentage of encounters that avoid law enforcement is remarkable. These data are incredible. And can you remind me how long they've been doing 24/7 ED rounds, the BERT team?
It's several years now. Does anybody happen to know? Yeah, 18 months to 2 years.
Yes, okay.
And I don't think it's overstating it to say that it's been transformational. We actually, we have a regular meeting between PES and the ED leadership just to talk about flow issues. And that was this morning. And BERT and having a psychiatrist in the ED 17 hours a day has really been a huge change for the emergency department, especially as we've been managing a lot of clients there who have behavioral health issues. So I feel really good about the BERT team in the ED, as well as the team that rounds, in the larger areas of building 25 and 5.
Yeah, remarkable work. And we please extend our gratitude and awe for what they've been able to accomplish. It's really remarkable. And I think beyond what we had hoped when we first heard about it, and it's fully staffed at this point as well. And I know there were some issues maybe 2 years ago or something, whether we could completely fill the team. And it sounds like it's gone quite well. So it's really an accomplishment. Are you planning on publishing this anywhere?
Yes, working on that.
That'd be great. I mean, because other institutions could really benefit from this work.
Yes,
And you have the data. I mean, the data fantastic.
right. Journals are very particular about what they want to see with data. And so I think because the team hasn't been in operation for that long is part of what the barrier is, but we'll keep working on it.
Thank you.
A good magazine or newspaper story about the success, the growth and success of the program, I think would be an incredible thing.
Yeah, you're right. You're right. I know our communications team is really exceptional, and they're always looking for things to highlight, like the social medicine team, which we wrote about in the narrative part of this.
Especially in national media, San Francisco, we get certain kind of attention usually, but for this, something this innovative and innovative in a space that is incredibly fraught, think is important for people to see that it can work and it's working here.
Yes, you're absolutely right.
Great. Thank you.
Thank you.
Thank you, Dr. Ehrlich. Can move on, I think, to the True North, well, you're staying, True North scorecard update.
Who's the next presenter?
I will pull up the presentation.
All right, so I'm going to kick off a presentation about our True North scorecard. Just to remind you, this is our quarterly update on our True North progress. You have the scorecard in front of you, and each of us who own primarily these, each of these strategic initiatives will comment about them. And I'm going to kick off talking about equity. And equity has a special place on this scorecard because it has its own metric, but also it is really imbued in all of the other strategic initiatives. For the departments driving equity, this is the percent of departments choosing an equity driver at the PIPS meeting. So every month you see that change a bit depending on which departments are presenting. And we are in the green. Our target in calendar year 24 is 65%, and we are at 80%, which is the running average over the course of the year so far. I think the challenges and opportunities for this one are the same. We have an exceptional team who coaches departments before they present at PIPS. And it is really, I think, through that coaching that departments have been able to understand that, choose metrics that they can drive related to equity, and to be successful with that. So I think we're just going to continue with that because it's been very successful heretofore. I will be back to you when we talk about the True North outcomes, but now I'm going to turn it over to Adrian, who's with us remotely today to talk about patient safety.
Good afternoon, Commissioners. I'm hoping the audio is okay. I've got a sore throat, so if my voice is a little croaky, I apologize. I'm going to present, first of all, achieving safe and equitable patient care. So we have 3 drivers, 2 active drivers, a hospital-acquired pressure injury, which is measured in 1,000 per 1,000 midnight census rates, and our target for that is 20. Our performance is outstanding, and we continue to see a very low actual observed rate. We're down to 0.10 per 1,000 midnight census rates, and we can really look at the ICU's performance and med-surg's performance. In ICU, it's been over a year since we've seen a HAPI in a patient there. Falls is our second active driver, and that's also measured in 1,000 per 1,000 midnight census with a target of 0.45. We're not quite at target right now. We're at 0.64, but that our fall rate has remained stable. And when we really do a deep dive on the falls that we see in patients, we're not seeing any significant injuries or minor injuries that we see. Our last driver that's in development is the sepsis. We're measuring percentage of bundle compliance with a target of 59%, which is based upon CMS star rating. Currently, our bundle compliance is low; it's 27%. But I would measure some of our success in that rate is we've had the group come together. They've completed the left side of the A3. They're working on countermeasures on the right side of the A3, and it's a really robust multidisciplinary team that's been working on our sepsis outcomes. The countermeasures, one of the countermeasures that we're continuing to work on that are focused on falls is partnering with our bed vendor. They have been trying really hard to work with us and demonstrate some of the technological and virtual strategies that can be used with the beds that we have in the hospital. So we're really looking at how that can integrate into our other electronic systems before we can commit to that. But that's been one additional countermeasure that we've been exploring in the last couple of months. I will stop there and ask if there are any questions or pass it on to the next presenter.
Probably the next presenter, so we can do them all at the end.
Sure. Let's do all the presenters so we can get through, and then the commissioners will ask questions.
Sounds great. So I'll keep us moving forward then. Gabe Ortiz, Chief Medical Officer, and I'll be presenting the strategy harmonizing and synergizing access and flow across the ZSFG campus. I partner on all of this work with our interim Chief Nursing Officer, Jillian Otway. And there are 5 KPIs embedded within this strategy. The KPIs are multifaceted due to the complexity of the patient access and flow. And so you'll see that the KPIs touch various parts of our clinical operations across our campus. So the first KPI, emergency department, decreasing % of time spent on ambulance diversion. Our year-to-date performance is 45% diversion, and our target is to be at 35% or less. Busy winter, and so I think kind of the performance there is on a strong downward trend. And so I can reflect more at the end of my reflections here on how we're doing. But I'll present the next KPI before kind of highlighting successes and challenges. Another KPI within our emergency department is the % of patients who leave without being seen. Our year-to-date performance here is 5.9% of patients. Our target is less than 4%, and so we want that to move down. This has been also a fluctuating metric, and Susan alluded to some of the challenges, including staffing, but in addition, the kind of busyness and number of patients that are being seen and number of boarders that we have on any given morning or any given day, stretching our teams thin. The next care area that's touched on here is our perioperative care area. The KPI here is the % of add-on cases that are completed, with our year-to-date performance being 65% of those cases completed within the allotted the target time, and our target we'd like to reach 95%. The teams have been doing interesting things in terms of leveraging block times that are not utilized by services to try to increase this rate, and you have seen an increase compared to calendar year 23 baseline. And more to do here, and we're kind of very hopeful that with our OR expansion plan that will start in the fall, that will continue to drive this down. In terms of the specialty care clinics and how they touch our patient access and flow metrics, the KPI here is the % of clinics with a third next available appointment within 21 days for our patients. Our year-to-date performance here is 86%, and our target is 90%. So we'd like to drive that up. It's very close to target. I mentioned, for example, audiology kind of staffing up and other specialty care areas doing something similar. We're also working with the health plan on grants to increase nighttime clinics and weekend clinics to increase that access. And this is so critical in terms of primary care and specialty care in terms of protecting our patients and kind of their wellness and precluding or preventing admissions, the need for admission if they're getting adequate care. Finally, the final KPI here within the Department of Care Coordination in close partnership with our inpatient care areas is driving down the number of lower level of care patient days. As kind of presented in some of Susan's data, this has been rising over time. Our current year to date is 1,981 lower level of care patient days per month. And our target, really as low as possible, our target right now is 1,100 lower level of patient care days per month. This is quite a complex problem linked with kind of the ability to kind of connect patients to needed community services. The recent recertification of Laguna Honda is really encouraging. We have a significant number of patients within the lower level of care days bucket that are waiting for true skilled nursing facility services. And so we're hopeful that at least that subset of patients that are kind of stuck at the hospital for lack of a community placement will be assisted by that recent development and all that hard work over the years to kind of be back online. And so I'll highlight kind of a success coming, alluding to how busy the hospital has been, there's been a very high demand specifically for internal medicine services on the inpatient care areas, which has been quite a challenge. But a success in this challenge, within this challenge, has been the partnership that the clinical services have demonstrated in terms of we've generated a overlap admission diagnosis protocol, which we've been piloting to be able to admit patients to an alternate service, offloading the internal medicine service. Admission diagnoses like small bowel obstruction that initially is not thought to require surgery, or osteomyelitis that's not thought to require surgery, and abscess that's not thought to require surgery on admission, being admitted to an alternate service, a new epilepsy or stroke, being admitted to neurology, for example, or some of those other surgical conditions being admitted to one of the surgical services. It's helped a little bit. I would say before the pilot, the medicine census was averaging 102 patients on average. And after the pilot was initiated, their census has come down to 96, which is still extremely high for that service. And so we continue to explore other countermeasures, which I'll highlight in terms of one of the PDSAs that we're hoping to pilot. So that's been a success. Just the collaboration has been really wonderful to see. We get together weekly to discuss the status of the different services and kind of how folks are working together. And I think the culture and the openness and communication across the services has been a kind of a development as a result of the pilot that kind of highlighted the importance of having effective communication and triaging those patients. A challenge, I'll say, is kind of the high levels of boarding. That drives kind of back the ability for the ED to be open to ambulance traffic, to care for patients in the waiting area, patients who are leaving without being seen, and put strain on kind of really the entire kind of campus in terms of our ability to meet the demand for services. There are multiple things that we're exploring, one of which was the overlap admission diagnoses. The medicine services is hiring a nurse practitioner, which is a role that's been vacant for a while, to be able to restructure our approach in terms of managing some of the lower level of care patients to create capacity for the rest of the teams to be able to continue to care for acute patients. And then the PDSA that I'll highlight is in looking at this problem and taking a larger picture view across the city. There are hospital campuses across the city that are not overflowing the way that we are. And so we're exploring piloting the ability to transfer our boarding patients, if appropriate, to one of our local hospitals, whether that be St. Mary's or St. Luke's or CPMC is still kind of being explored. And so we'll be trying to pilot on a small scale that workload to see if we can create a safety valve in terms of moving patients to an alternate hospital that may have capacity, is not full, and has the skills and expertise to be able to care for those patients whenever we're at a critical level, as that's to be determined, to be able to then continue to move patients through our hospital, our emergency department, and not kind of improve our diversion rates and all the other metrics that are presented here. So I'll stop there, and if there are no immediate questions, I will turn it over to my colleagues. Adrian will be presenting the next one.
Hello again, Commissioners. I have the privilege of presenting on behalf of Ayana Johnson and the team, which I'm part of, for the Thriving Together, Building a Supportive and Safe Environment for ZSFG's Dedicated Workforce. Our KPI, we have two main KPIs. One is operational deployment of staff experience efforts at department level to engage staff, and secondly, safety, physical assaults with injury. Under that first operational deployment, we're really looking at departments at ZSFG who have a framework at their level to make improvements based upon what we heard from staff in the survey, focusing on areas that have a correlation to engagement in relation to the likelihood to recommend ZSFG as a place to receive care, employee well-being, employee safety, and communication. It's taken us some time to put together our baselines for the first KPI, but we are able to give some baseline data for that now. Out of the departments that report to PIPs, we're going to use a similar methodology as we do for equity, and have departments report out their staff engagement, employee engagement work as part of their PIPs report. So 35% of departments already measure and report out a staff experience metric as part of their PIPs reports. And as a subset of that, 15% of departments that do 15% of departments that report to PIPs, the work that they're doing is already in alignment with what we're looking for as part of our A3 for staff engagement. So having that baseline is a great place for us to start, and it was also a little higher than I think we were expecting, so we were really encouraged by that. And then physical assaults, we have a goal of 4. We're at 5.6 for the year, 5 for the month of June. Sorry, for the month of May. So again, we're encouraged that that number has come down. And we continue to work on that. Some of our successes have been around the dashboards for their employee engagement survey that are now unit and department specific, and that provides leaders to really the information to be able to develop data-driven solutions to what we have heard from staff that work in their areas. A challenge has been how we can be transparent with the data and retain the anonymity of the respondent. So if there's less than 5 respondents in an area, we won't be able to drill down on that data because it could risk the people in that department not being able to be identified, which we certainly don't want to do. We are partnering with the teams partnering, the employee engagement team and the PIPs team are partnering to see how we can mirror some of the work that we've done around equity to support those people, but it's similar and it's different. So it's really working out the right kind of support and the right kind of resource for those teams that are coming and developing new metrics with us. I think that brings me to a close, and I will hand it on to the next presenter, who I think Eric Wu's there for finance. Oh no, it's Hemel. I apologize. Hemel
No.
is gonna...
Thank you, Adrian. Good afternoon, commissioners. I'm Hemel Kanzaria. I'm the Chief of Performance Excellence at ZSFG. Nice to be here as always. I'm reporting out on our strategic area, which is the revenue cycle optimization, where I partner with Eric Wu, our Chief Financial Officer, on. So the goal of our strategy here is to reduce hospital billing denial rate from a baseline of 18.6 to 15.6 by July of this year, and we are just above or off target. However, you can see that we're making significant progress, and in the last 2 months, we've actually been below target for the first time. To my knowledge, this is the lowest denials rate that we've had since we've been tracking the data. Some of the successes since our last update, we've been working on a number of items. We have expanded the potential for observation services use at our hospital. So initially we were doing only Medicare beneficiaries, and we've started to employ observation services for Medicaid, especially through San Francisco Health Plan. We've also tried to tighten up some of our policies around surgical patients and what sort of their appropriate status is. So these are really following closely to Medicare guidelines. We have additionally been working with San Francisco Health Plan really closely. The team has, currently it sounds like San Francisco Health Plan is having some erroneous practices around denials that we've been giving real-time feedback on cases that were inappropriately denied. And that's been resulting in some improvement, we believe. And then we're working on our sort of real-time peer-to-peer communication where there's denials and we can sort of appeal in real time for patients that we're caring for. I think some of the challenges are in our sort of focus on our mission of our institution and equity. We want to provide, of course, the highest level of care to all of our patients. And so, for example, with patients who undergo a total joint replacement surgery, total knee and total hip, those are not on the inpatient only Medicare list. So they don't typically get admitted in other institutions. However, because of our patients having significant social needs like homelessness, it's hard for someone to rehab if there's not a place to rehab from. And so we're trying to figure out the right balance of how do we manage sort of pretty significant denials related to that, those surgeries, and there's a couple others like that, with ensuring that our patients have the best quality care, that we provide exceptional care for all of our patients, and we do it in a empathic and meaningful manner. Really proud of the team. This team is very multidisciplinary, involving sort of our revenue integrity team, our denials team, our Department of Care coordination that helps with a lot of the flow related initiatives that Dr. Ortiz spoke about, and several others. And as a clinician in this area, it's been a new opportunity for me to learn about other aspects of healthcare and learn from the team directly. In terms of our current PDSAs, I would say while we're having success, Eric and I are also taking this opportunity as new on the team to take a step back and look more broadly at this strategy and consider additional areas that should be, areas of focus for revenue optimization, whether that's revenue generation or denials mitigation. And so we're exploring sort of additional KPIs alongside continuing the work with denials. We are also really trying to drill into what are the main contributors to, for example, our denials right now, and where can we augment or add resources to. So one example of a positive movement in that direction is many other health systems are able to leverage additional software onto Epic. And so in the last couple of weeks, we've been able to go live with a new software called 3M that allows us to identify sort of clinical comorbidities and diagnoses in an automated fashion. And our sort of teams are able to benefit from that, where they can more quickly identify sort of the best ways to code diagnosis to maximize revenue. And so an example of that is when I'm taking care of a patient in the emergency department, I might write patient comes in with shortness of breath, and that might be my diagnosis. But probably a better way to do that that still matches the care that the patient provide is patients with acute hypoxia with respiratory distress. So sometimes it's like the coding and the nomenclature and clinician sort of education and leveraging technology to really advance what we can do around our revenue cycle. With that, I think I will turn it over to Dr. Ehrlich for discussion of the True North outcomes.
Okay, so the True North outcome metrics, just to remind us all, are ones that are meant to be set and followed over 3 to 5 years. So we don't see these big changes in these metrics in short periods of time. We wouldn't expect those. A great example of that is the CMS star rating. That has been a goal, a True North goal of ours since just shortly after I arrived, maybe 7 years ago. And it was 1 for the longest time, and now it's 2. And that was a result of all the work that we were doing on the KPIs that we just talked about now. They're 3 to 5 years. We expect to see changes. And I will say that we select each of these to be directly impacted over time by the KPIs that we choose on the shorter basis, right? So, another example of that is we included the sepsis bundle compliance in the safety metric because we knew it was one where we had opportunities related to the star rating, and because we saw that we just weren't providing the standard of care that we wanted to be. So we changed up our metrics there and included sepsis. So it helps us with our quality of care, and it helps us ensure that our star rating remains at 2 and above. The other True North outcome metrics we have, one is likelihood to recommend hospital to friends and family. That is our HCAP survey, which is a mailed survey, which is why we only see results once a quarter. Likelihood to recommend provider's office to friends and family is the real-time survey, so we have more frequent data on that one. And then we have likelihood to recommend ZSFG as a workplace, which is, of course, data we get from our DPH workplace survey, which we did a couple of years back now, and we will be, well, more accurately, our Human Resources Department will be organizing all of us to do that again this year. So on likelihood to recommend hospital to friends and family, you can see that overall we're at 76.1% compared to our goal of 77, so we're quite close there. Likelihood to recommend provider's office, we're almost as close, 77.6 related to 80%. And likelihood to recommend ZSFG as a workplace, we only have a baseline because we won't have an update to this until we resurvey. And then we are in the green for general fund spend not to exceed the budgeted amount. So that's where we are on our True North outcome metrics. I just want to pause and say a great thank you to our executive team that is managing this scoreboard. I'm particularly appreciative of Jillian and Adrian who are on the line, and then Dave and Hemel and Angelica and Eric and Mary will be helping us on our scorecard now. She's just joined our executive team not that long ago. With all of the turnover, it really takes the whole team to make sure that we're meeting our metrics. And we have such an exceptional team doing this work together. I really want to appreciate them. Happy to take any questions on any of this.
And there's no public comment.
Commissioner Christian.
Seeing how close you are, how close we are here, 76.1 versus 77, 77.6 versus 80, and then 33 versus 33 it's very exciting.
Yes, it is. Yes, it is. We're grateful, and we always want to shoot higher on these things.
Sure. Congratulations.
Thank you.
Yeah, this is great work. I did have two questions, and one is just a point of confusion of mine. In your equity, choice of equity goals, do they get established and then added on to as time goes on, or do some get sunsetted? How, I remember you've been doing that. In fact, there's been a remarkable uptick in the number of departments that have, I think, have been involved, especially from 2 years ago. So it's really remarkable how many have equity goals. But do you keep them going? Do you add to them? Do you sunset them? How is that going to work as time goes on?
Each of the departments presents to PIPs on a regular schedule. Usually it's annually, but different departments have different cadences. And each time that department has an opportunity to change up their metrics and to keep the metric they have for equity, change it. And as mentioned, there's a lot of coaching that goes on to help them decide which metrics are most relevant at the time. So that's how every time a department presents, it has the opportunity to change up what it's working on. Adrian, since you're part of the coaching team, maybe you want to say something more about that?
Yeah, thank you, Susan. We generally start a department off with asking them to stratify data and look at and begin to look for that. Once that department's done that and has stabilized being able to stratify data, we then ask that you start to look for disparity. Once they've identified disparity, we then ask them to begin to kind of find ways to address that disparity. So it's an iterative process that can develop over a few months in the lead up to a PIPS report, or over a few years as departments bring updates and new things that they have found. We have seen departments sunset some of their older equity metrics when they've re-looked at their data or they have addressed a problem and want to look for a different disparity to treat. So it's not a static once and done. It's a developmental and an iterative process. But as Susan correctly described it, it's really all around the PIPS coaching process so that the teams can identify their metrics with our support from quality.
No, thank you for that. That clarifies. Thank you. The other question I had is when we look at especially the emergency room and TNA and so forth. I was looking over the, the baselines that we have from the last 2 years, and you certainly set the bar for yourselves really high. I was looking at the diversion. Baseline was 40%, and you're trying to hit 35, and I think some of the baselines for left without being seen were also higher. So, are you setting your bar too high? You're so good already.
Ever. No, we really try to get as close to setting bars that are community standards as possible. And so for ambulance diversion, the best practice community standard would be 0, which we're reminded of by our colleagues at EMSA quite frequently. And for left without being seen, it would be 2%. So we really aspire to those goals, and we set targets along the way, which are represented as best we can set them by what you see here.
Thank you. That makes sense, and thank you. And it was so interesting what you said about hospital billing and these bundles that have different expectations and different compensation without any. And this is such a huge challenge that these social determinants are so ignored in compensation systems, even government compensation. It's so frustrating that there's no voice for DISH hospitals and for this population in general to try to adjust these compensation plans. I'm wondering if it's kind of hopeless or whether
It's not actually, because even at the federal level, Congress has recognized that social determinants need to be recognized when they set the star rating. And there was a point at which they changed the star rating to not penalize hospitals like ours so much. And if they had if they had actually said it at that time, we would have been at a 3. But they didn't. They got feedback and changed it back to the way it was. So it's not that it isn't recognized. I think people just don't, and lawmakers and others just don't really know exactly how to operationalize that.
I'll just add on both spectrums. So CMS has taken a great amount of interest. You heard during the PIPS report that this is the first year that we're being required to report on different social determinants of health domains. In the emergency department, I can say that we are, for the first time ever now, have an option to document around SDOH as a way to augment sort of our documentation and revenue generation standards. CMS is right now just requiring the data, and I'm hoping in the future they are going to both require some thing of health plans, and we see that with Medicaid reform efforts in California under CalAIM, which is focused on social and medical care integration. So that's sort of the hopeful part. I think that does require a lot of investment also outside the healthcare systems, to fix things like housing, for example. And so I think it's important for us to be a stakeholder at the table, but it's going to take sort of thinking about what our community needs holistically to move the needle on some of our domains. On the more skeptical side, I do think realizing denials management, there's a lot of administrative burden placed on a lot of time that our team spends on just getting paid for the things that we do. And I think, that's I understand why it exists, and we're trying to figure out how we can be most efficient with that. But there's so much other sort of patient care that our teams need to focus on, and some of them are the same care coordination nurses, for example, that are trying to do both, make sure that the patient gets the best care so they can get a timely discharge, and also prove to a payer that we're should get paid for the care we provided. And I think we're learning what those best practices are, and so there's opportunities for us to continue to grow. And I wish in an ideal world we didn't need to spend a lot of time on those, and we could really focus on the patient care part.
Yeah, it's so unfortunate. Do you think there'll be any changes if the administration, God forbid, changes? In other words, leadership at CMS, and there's such a denial among certain sectors that social determinants matter. In fact, once someone told me, that one of the reasons healthcare costs are so high in the United States is that many items that are in the social services bucket in like European countries and other countries we're compared to end up in the healthcare bucket in this country. Yeah. And it's almost like the country's in massive denial.
Almost.
Yeah.
I don't know how to comment on if the administration changes or CMS leadership changes. I do feel Adrian and Dr. Hewen and I had a chance to talk with CMS directors recently in DC, and they are a really inspiring group that, is similarly trying to figure out how to advance equity through what they do. And it was really pretty inspiring. I think it's an important topic, and there's really growing evidence that addressing social needs impacts and improves healthcare outcomes. And we're lucky to be in a place here at the General, at UCSF in San Francisco that recognizes that and is thinking about, patients' underlying social, environmental, economic, and political factors that advance health. And so I guess we'll see how it goes.
Well, that's another area where, as Commissioner Christian said, it would be great to get an article in the New York Times or somewhere that makes the public more aware, because so many people have no idea. So,
And highlights the fact that, what we recognize as being social determinants of health are things that we used to take for granted as a country that people had. And they disappear, and they disappear in a way that is invisible to everyone unless it's affecting you. And it's just this assumption that remains that, oh, of course you have these basic things, but you don't. So it's kind of a mess.
And we're here to fix it.
And you're doing a good job. You're doing a good job. I don't want to take too much time with this, and this is definitely a learning point for me, but you were talking earlier about billing and how, you have an episode of diagnosis, whatever it is, and there are several ways to code it, and some of them pay more than others. Is that electronically based, and you do your work,
Yeah.
the doctor does their work, and then, there's the billing, and then does it go to the billing department, and the doctor's written down something, and the person in the billing department then decides what to code it as?
Yeah, so we have multiple teams that work on this. So the clinician does their work initially, and then we have a clinical documentation integrity team that reviews every note, every H&P, every progress note, every discharge summary, every day. And so there are human resources going into chart review and trying to figure out, okay, Hemel said, shortness of breath. He didn't say pneumonia with severe sepsis. And so trying to look at the chart to see if those, where there might be opportunities. The example I gave, if someone is statting below 88%, that is considered acute hypoxia with respiratory distress. And I may not know that as a clinician. I found that out in the last couple of months, And so then that team queries the clinician and will send me a message at Epic, through Epic, saying, hey, Hemel, I realize that you didn't really appropriately document. Can you do some can you look at the chart and consider this based on these factors? So they sort of coach me through it. Sometimes that takes sort of persistence, and we have a great sort of CDI team that is really transforming this. They've grown over the last couple of years, and they have tremendously supported this work. So after they finish the coaching of the clinician, there's also a coding team that then independently looks at, okay, now the CDI team has signed off on this. The coding team looks to see what are the right codes that should go on this chart. Again, a lot of that is human resources. And so I think there is an opportunity to leverage technology better. And so I mentioned that software that I'm really hopeful is going to help us tremendously. I think there's probably a huge opportunity for artificial intelligence and large language models that we're not using in this space, but I think we probably could in the future. So that's a long-winded response.
No, it's not. Actually, it's perfect. Thank you.
Yeah.
And this is an area where private, not-for-profit, and for-profit hospitals invest a tremendous amount of resource, and we're just catching up. We have been able to justify investment because of the revenue that it brings in, but most, public safety net hospitals like ours are behind the curve on this type of thing because we're focused on taking care of the social determinants of, patients' healthcare needs, for example.
thank you.
Very helpful. Thank you.
Thank you for the great presentation.
And Mr. Wu gave me an email follow-up on the timing of the QIP payments.
Oh, yeah.
They're typically dispersed after the performance evaluation period. We're just starting to receive payments to the QIP programs from calendar year 2022. So it seems like it's a little bit behind.
Stays behind.
Okay,
Thank you for that, by the way.
Thank you.
All right, it's okay to move on to the next item.
Sure,
Thank you
yeah.
very much, everyone.
Thank you.
The next item is the hiring and vacancy report.
Hello, good afternoon, commissioners. My name is Kim Walden, and I'm Director of Staffing for DPH, and I'll be reporting out for HR today. I'm happy to share that for the month of May, the hospital's vacancy rate decreased from 6.91% in April down to 3.27% by the end of May, which is a 3.64% decrease. We've hired a total of 56 employees in May and had 4 separations with no retirements. I'd like to highlight in June of last year, we were at 10.86% vacancy rate, and today we are at 2.96 vacancy rate for the hospital. So within 1 year, we've reduced the rate by 7.9%. The RN vacancy rate has decreased from 2.46% in April to 1.99% in May, which is about 32 vacant FTEs. And some of the initiatives we took to mitigate challenges for nurse hiring are in the month of May, we appointed and hired 21 nurses for ZSFG. This includes reassignments. We continued mass hiring efforts across DPH, and I'm really proud to share that we met our goal of achieving a 0% vacancy rate across the department for budgeted positions. We've engaged our recruiters to source candidates for hard-to-fill units, such as jail health. And in the next couple of months, we anticipate implementing a new online salary placement tool to facilitate salary determination. And this will help really streamline the process and provide candidates with their salary placements earlier in the onboarding process. And so this concludes my report out, and I'm happy to take any questions.
And there's no public comment.
Well, congratulations on this report and on the wonderful trends that you have. I just had one question. Given how wonderfully you've done, especially with nursing vacancy, and I know you do have an emergency care training program upcoming, will that in any way affect the cadence of the training programs you've done? Because so often, you know, when you have had these wonderful programs to help in recruitment for various units, they've been so successful, but it also takes a lot of effort, obviously, to do those programs. So is there going to be any change in the cadence of those as you know, the vacancy rates continue to fall?
Specifically to the training programs?
Yes.
I'd like to ask possibly Jillian to provide a response for that.
Hi, good afternoon, commissioners. In terms of the cadence for the training programs for the nursing staff, in different areas, we have different timelines. So for example, in the OR, they do training programs every 6 months because it takes approximately 6 months to train an RN. In the ICU, we have been doing programs every 3 times a year, as well as in the ED and in labor and delivery. And Med-Surg will also do programs 3 to 4 times a year.
So that will continue in the same cadence, no matter what the vacancy rate is. Great. I was curious. Thank you. That was the only question I had. Wonderful.
Thank you.
Thank
We can
you.
move on to other business.
No other business.
Hearing none, then we have public comment, which we have none. So we can move on to consideration for adjournment, which I think this is the quickest meeting I've been to in 15 years I've had this job.
So moved.
Second.
All those in favor?
Aye.
Aye.
Right, thank you,
all
everyone.
very much. Congratulations on your wonderful work.